My name is Drew Park. I'm an assistant professor here at Brown Medicine and part of many harm reduction related research activities in Rhode Island. So I want to just give a formal introduction. So Haven coordinates the syringe exchange program at Outside in Portland, Oregon, and she has been involved extensively in advocacy, not only in Oregon, but nationally as well, and has worked on several important policy initiatives. So without further ado, I want to hand it over to Haven. Welcome.
Thank you for having me. I'm excited to be here. I'm going to ask for a little bit of grace. It is very early in the morning here in Oregon. I have not finished my coffee yet, so if you see me sipping my Starbucks, sorry, not sorry. I gotta take care of myself first and foremost, but I really appreciate y'all having me here. I'm Haven Wheelock. Like Drew said, I've been doing harm reduction work for over 20 years. I've been slinging needles and naloxone for at least that long. And I'm really excited to talk a bit about our decrim effort. And just for context, actually, I'm going to wait and talk about that when I turn on my slides. But yeah, I'm grateful to be here. And with that, I'm going to attempt to share my screen. I've practiced. It should work. All right.
Yep, we see it. Thanks
you
so
got
much.
It? Awesome. Yep. Awesome. So this is like our basic, like how we did it, what happened, how it works kind of slide show. I'm going to try and keep this like short so we can have a conversation and like do questions as much as we can, because that's more fun for me than talking at a bunch of boxes with no pictures. I'm Haven Wheelock. I work for an organization called Outside In here in Portland, Oregon. We're one of the oldest syringe access programs in the country. This slide deck actually was created primarily for the, we put these slides together for the National Harm Reduction Conference. So if you were at that conference and saw me speak there, sorry, nothing new. But I want to give credit to my co-presenters at that conference because they did help with the slide deck. So Kellen, Ron, and Tara all helped put together this information. And I want to give credit where credit is due. So I am Haven, but these other people also helped with this from both Drug Policy Alliance and the Health Justice and Recovery Alliance. So I'm not 100% sure how much y'all know, but I'm going to kind of talk about how we got like the early campaign, how we did it, how it went, and then touch on what the measure actually does and then some outcomes going forward. So initially and currently, the campaign was Measure 110. So in the state of Oregon, you can do citizen petitions to get legislation move forward. So it's called a ballot initiative, which means we had to collect signatures as opposed to going through like the legislative process and finding a legislator to like sponsor legislation. We did do a citizens petition. So in 2019, there was a pretty amazing group of us that came together. The Drug Policy Alliance had reached out to us about wanting to like move towards decriminalization. And we all acknowledged that criminalizing people for substance use is an utter failure. It's never worked. If we could arrest our way out of this predicament of addiction, then it would have worked by now. We really acknowledge that in Oregon, so some Oregon context, right? Oregon has some of the highest addiction rates in the country. We're like #1 for methamphetamine use, according to SAMHSA, 2 or 3 in terms of prescription drug use. Our overdose death rates historically have not been as high as overdose death rates on the East Coast, but that's just because fentanyl hadn't hit our only recently has hit our drug supply. Fentanyl is not something we saw a lot of as a contaminant in our drug supply until the last couple years, when it's not actually being seen as a contaminant. It's people are just doing fentanyl. And so we have really high rates of addiction. And simultaneously, we also usually are around 50th in the nation for access to mental health and addiction services. We historically have had grossly underfunded service delivery for people who use drugs in our state. I'm hopeful that that will be changing. But really, we do consistently rank 49th, 50th in the country for access to treatment. And that's including like states that didn't expand Medicaid, right? Like it's real bad. And so from a national perspective, DPA was really like, okay, who's going to benefit the most? And at the same time and simultaneously, like, where is it politically feasible to make this happen, right? And so Oregon is a pretty progressive state. Well, Portland is pretty progressive, and we pulled the entire state with us because of our population. So that is part of like our addiction profile. And then when we think about Oregon's history is pretty gross in terms of white supremacy. We were actually founded as a white utopia. We were one of the first states in the nation to ban Black people and ban slavery in our state. Not so much that we were opposed to slavery, but because we didn't want Black slaves coming to live in Oregon. And so that history and legacy of white supremacy is still very present in our state. And a lot of the policies around drugs and how we treat people are still really, I mean, and this is true nationally. I don't want to like pretend that Oregon, like our drug policy was any different really than drug policy across the country in terms of white supremacy. But Oregon's history of white supremacy means that like the racial disparities in our system were and are pretty like nasty and gross. And so when we're thinking, I'm assuming most of this group already understands that the war on drugs is bad. And so we really wanted to like move from thinking about drugs and drug use from a moral criminal issue to like access to services and healthcare. And so those conversations started in 2019. We pulled together some really cool and diverse stakeholders to like draft what we were thinking we were going to try and do with this initiative, and we filed with the Secretary of State to start collecting signatures. This is our launch party. This was the first time we gathered people together in hopes of, starting to collect signatures, starting to like get this ball rolling. I want to call out that this party happened on February 29th, 2020. I'm really glad this wasn't a super spreader event. Like in retrospect, knowing what we know now, I'm looking at this image and I'm slightly terrified. But we were able to bring together a really cool group of like strong advocates from across the state. These are the chief petitioners on the initiative. So obviously me, and then Janie Gullickson is a person in long-term recovery who runs an organization that provides peer support across the state, like hires and like trains peer support specialists across the state. Anthony Johnson is a badass drug policy reformer who worked on our marijuana legislation. So the three of us really took the charge of getting things rolling. So once we launched, we started doing a lot of work around building a really diverse pool of support. Every time I look at this list, it like makes me really happy. But I think so often when we think about healthcare policy and like criminal justice policy, we tend to like think in our own little wheelhouses around these things. And I think we did a really cool job of breaking down some of that. We did a lot of work to recruit and get support from the labor unions here. We found them to be incredibly helpful in terms of like getting folks on board. Several of the labor unions were willing and excited to do this. So like on top of like our, like who you would think of as your like default partners, pulling in some of the less like the Oregon Food Bank was all about this measure and were super helpful in recruiting. I'm really proud of us in that, we launched on February 29th. And granted, we've been collecting signatures before that, to be clear, just because we initially were like trying to keep what we were doing quiet to avoid opposition. And we launched in 2020, and then stay-at-home orders happened literally 2 weeks after our launch party. And so we really had to shift and adjust how we collect signatures. And at this point, I thought there was literally no way we were going to reach the signature threshold for us to get on the ballot. Like I could not envision a world where without having canvassers on the street, without being able to like sign people up at bus stops, that we were ever going to collect these signatures. And then one day I came home from work and there were 50 envelopes with signatures in my mailbox. And I cried, not gonna lie, I cried. But we really did shift to like a mail-in signature gathering campaign that somehow worked. I don't know how. It felt really magical. I would not suggest doing it that way, but it was an effective strategy in like the times we were in. And so we collected the signatures, we got on the ballot. We were able to pass the measure in November by a pretty large margin. It was pretty like within moments of polls closing, we knew we had won this election. It was really cool. And I think it's important to like call out that we never actually had any formal funded opposition. There were plenty of people who were like not happy about it and opposing it, but no one with like money was really trying to like block this initiative, which I feel I was a little surprised about. To be honest, like we had some of our like state DAs, our county DAs, oppose it and talk about it, and like go on the media in opposition. Some of our recovery groups were in opposition of it. When it came to the recovery groups, it was very much the argument like it's too much too fast, right? You can't. We don't need to go all the way to decrim yet. Don't think drugs should be criminalized, but it's too soon. We also had a fair number of arguments around like you're putting because we were decriminalizing drugs before services were scaled up. There was a lot of conversation about putting the cart before the horse and all of that. To that, I have to say that the harms associated with incarcerating people, especially during a pandemic, associated with drugs is more than the delay in getting services out. So what does Measure 110 do? I think when I talk to folks nationally about this initiative, the most common thing people know is that we decriminalize drugs, right? And everyone, like, that's what they go to, is that we decriminalize small amounts of drugs. And we did do that. I think the measure does actually two really, really super cool things that people don't realize. So one thing is that it reinvests our cannabis tax revenue over a certain threshold into non-Medicaid billable services for people who have addiction. So harm reduction services, housing, peer support, long-term recovery supports, a whole wide range of services can be funded with this. But it is not to be used for anything that is Medicaid billable. We have taken some heat for that. And I don't know if going forward, I would agree that that was what we should have done. I don't know. I feel conflicted about it. But as of right now, like if you guys are thinking about this in Rhode Island, I would say that is a conversation that should be had and really thought through, because I'm not 100% sure I would do it the same way again. In full transparency, right? This is not perfect. We were the first. We did our best. Hopefully others will do it better as they move forward and learn from what we learned. So this biennium, that's going to account for about $300 million of cannabis tax revenue that is going to community-based organizations to support people who use drugs. It's pretty magical. And that money will continue to roll out. That cannabis revenue will continue to that number will vary depending on how much weed people smoke. Oregonians like their weed. So there's that. So we're hopeful that this will be a continued investment for our community. The other thing that I think this measure does that is very, very cool is it created an accountability council and an oversight council made up of people with lived experience of substance use and incarceration. And that's who gets to decide how money gets spent. Which is just really rad, and I'll talk more about that council here in a moment. So like I said earlier, it really is about creating low barrier access to the money is to be spent on low barrier access, peer recovery supports, harm reduction services, and supportive services for people who are using substances. People often ask, what is the decrim part of this? How much can you have? Those kind of things. So what the measure did was it basically took what was already in state law and just created a new class, which is a Class E violation, which essentially means that if you get stopped with less than this threshold of drugs, it's $100 fine. And that fine can be waived by doing a health assessment with a peer support person. And then after you've completed that assessment, you can have those charges waived. Or you can just pay the fine if you'd rather do that, and that's fine too. But anything over these thresholds would fall into either a misdemeanor or a felony, depending on how much you have. I find some of it incredibly funny to me, 1 gram of heroin might be a day's worth of heroin for somebody. 40 hits of acid is not a 1 day per use for folks who are, that's a very good party perhaps, but not necessarily a personal use amount. But that's how the law was already written. We couldn't in our initiative change those thresholds because ballot petitions can only do a certain number of things. So if we wanted the cannabis money and to create this Class E violation, we couldn't really monkey with where the thresholds land. But I'm hopeful in the future that we will be able to adjust that a little better. So this is kind of our timeline on where we're at. It's a little old at this point, but it was a much slower process than we thought it would be in order to get the money out. We decriminalized drugs in February of 2021. We were able to get some early money from the legislature to create what we call access to care grants. Those grants went out early to organizations to try and start building this up while the rest of the Accountability Council was figuring out how they wanted to do the long-term grants, how to build these what we call behavioral health resource networks, or BERNs. So every community has to have all of the services that 110 is supposed to provide. They have to be able to do that in every community. So while all of that was getting figured out in 2021, really grants started happening early 2022. I'm really excited to be able to do, we're working on our expansion now and expanding out in ways that I've never dreamed I would be able to as a harm reduction service provider. So it's very, very cool. The Oversight and Accountability Council is these are their rules and what they're supposed to be doing. I am really proud of this piece of how this worked. It is messy. I will be the first to admit, if you watch one of these meetings, it's really messy. And to me, a lot of that has to do with the lack of support from the Oregon Health Authority to this council in teaching. We created this council of people because they are experts in our addiction service provision. They are experts in how incarceration operates. They are not experts in Robert's Rules of Order. They are not experts in how to write an RFP for a grant. And so hopefully going forward, they will get much more support in how to make this process easier. Again, a place that I think, if Rhode Island is thinking about moving in this direction, you would want to really think through. I think we did the right thing by creating this council and giving them this power. And I would hope for more support to them in order to really do it right. So these are the kinds of humans that we have on our council. Many of our council members are multiple of these things at different times and in different roles. But the actual legislation says these are the kinds of people. And if you look at this list, I want to call this out because I like it. Law enforcement is not on this list. Judges are not on this list. We very intentionally made sure that law enforcement was not trying to make decisions about how treatment should be provided and how healthcare should be provided to people who use drugs. And so I think that to me, the fact that there aren't law enforcement has a role and is a key stakeholder in some ways around the addiction crisis. When it comes to treatment provision, I don't believe that they should be. They're not doctors. So the demographics of the council currently, the council's over half BIPOC, which for Oregon is bananas. Oregon is a very, very white state. I think Portland, and don't quote me on this, but I think in Portland, 94% of people in Portland identify as white, non-Hispanic. So we are a very, very, very white state. And so to have a council that is made up with such a beautiful racial diversity is rare and cool. We do have tribal representation for on the council. 16 people have lived experience of substance use disorders. It's really across the state. We have both rural and urban folks on the council. I think it's really cool to acknowledge that over a third of the council has been incarcerated at some point as well, which I just think is rad. So how's it going? I will say first and foremost that it is too early to tell how the health outcome stuff is going. We're working on it. We're looking at it. But because the money came out so very late, we don't have a lot of data on that at this point. because we are just now building out services. So most of what this is going to be looking at arrest data. So this is from the Oregon Criminal Justice Commission. It really is looking at arrests for drug possession from January 2017 through 2022. We, as you can see here, when the pandemic hit, obviously we worked to lessen the number of people who are in jail and prison. That was successful. We anticipated that once decrim actually went into effect, we did continue to see a decrease across time in the number of people who are being arrested. So the data itself plays this out. I also will just say, as a direct service provider working with people who use substances, like there was a really big shift in how all of these things played out and like what clients were telling me about their experience interacting with law enforcement around drug possession. We really are not seeing cops issuing, like people aren't really getting arrested. They're not really like even issuing tickets. They just don't want to do the paperwork. So, whether or not we needed that Class E violation or not, I don't know. But because we aren't seeing a lot of tickets being written in our state. So in that regard, we think it's working. In terms of like, did it cause other unintended consequences? This is a study by RCI looking at calls for service to 911, which is not, it's a proxy measure, right? It's not like the best one necessarily, but when we look at cities similar to ours in our area, we don't really see, like the trends are kind of the same between Portland and Sacramento, Seattle, and Boise, in that like if 110 had caused an increase in crime, we would expect it to be different than in our like surrounding cities. And we really just we're not seeing that as of right now. So that is also cool. Off the record, we are looking at overdose death data right now. I'm working on a study looking at overdose death data, Portland compared to other cities. And preliminarily, we aren't seeing an increase of overdoses different than what we would be expecting. When you look at the raw numbers of overdoses, it does appear that we have had an increase in overdose death in our state. However, that has more to do with the fact that fentanyl has emerged in our drug supply for the first time than anything having to do with 110. So, I mean, that's forthcoming. That data is preliminary. That might change. I could be wrong, but that's kind of what we're seeing right now. Other cool things, we've been able to engage with 16,000 Oregonians using just the initial $30 million worth of care, community providers. The pandemic was really hard for many of our community providers, and we thought we were going to lose a lot of providers due to the pandemic. So this influx of funding has been incredibly helpful. Again, it's a lot of money. It's really exciting. So the initial access to care grants is here. This is kind of how they broke it down. A lot of money went to harm reduction, housing assistance, peer supports, other things. The burn grants are what is rolling out now. It's like 10 times the amount of money. It's very, very exciting. And that's kind of where we're at with all of that. We've gotten a lot of press, a lot of really good things in terms of like talking about how all of this stuff is rolling out in general. A lot of services across our state. I mean, Oregon's a really big state. It takes 13 hours to drive from one side to the other. So the fact that it is so diverse is pretty rad. Eastern Oregon getting $3 million for services is just unheard of. So I'm just going to flip through those. we've got a really strong focus on making sure that those most impacted by the war on drugs, so Black and brown people, are really centered and prioritized in all of the scale out efforts. So a ton of like organizations that only speak Spanish, for instance, or serve Black and brown people, were able to access these funds and be prioritized for these funds, which is cool. Since it's passed, I mean, it's been a controversial thing, but since it's passed, we still have really high support for this work, and bipartisan support. So we did a poll early in 2022 looking at if people still supported focusing on healthcare versus criminalization. All likely voters, about 72% in our state, said yep. There was a little variation, but even Republicans in our state still the majority said, yes, we do support. 54% of Republicans were like, yes, we should be using a healthcare approach versus a criminal justice approach in our state. Democrats were like 90%. The majority of likely voters said that they wanted Measure 110 to stay in place. A lot of the reason we were doing this polling is we had several candidates for governor. I think that might even be the next slide, pushing, and many people running for like state office were really talking about repealing 110, and we wanted to make sure we had evidence that it was still supported. So this is what we're hoping to do in the future, like really expand services and a lot of evaluation on what is happening. That's coming forward. This is an example of an attack ad that came out during the campaign. 110 was a big issue in our gubernatorial campaign. I'm very grateful. There was only one candidate that supported Measure 110, and Tina Kotek became our new governor. So that's hopeful that we won't be fighting this kind of messaging for the next 4 years. I think lessons learned, I think implementation is really, really important. Like it's much easier to get something passed than it is to get it done. As you all know, in terms of overdose prevention sites. And, like getting the rules passed is one thing, getting services out is another. I think we need to move away from the ticket system and the civil penalties. It's just not helpful. There was a lot of conversation about law enforcement helping people get into treatment, using those fines, but we find law enforcement are just not wanting to do that work. I would love to see a world where people like expungement happened instantaneously or retroactive, so people with a possession charge from before get that cleared just automatically. Our measure did not do that. And with that, I wanted to make sure I left a bunch of time for questions because I'd rather talk to people than show slide decks. So with that, I'm going to stop sharing my screen and see what questions you all have for me. Feel free to come off mute, off camera. I haven't been looking at the chat, so if you chatted questions at me, I didn't see them.
Thanks so much, Haven. Thank you. I mean, this is the second time me hearing this talk, and I still learn so much every time, and just blown away by all of the amazing work that you all have been leading for not only Oregon, but for the whole country. We have one question, and actually I'm going to hand it off to Haley McKee from the COBRE to help moderate. Haley has a lot more experience in the policy arena than I do. And I think we already have one question in the chat and hopefully more. There are about 40 people still on the call, so I think we're going to have plenty of interest and questions. So over to you, Haley.
Thanks, Ju, and thanks even for your presentation. Congratulations on all the success you've had in Oregon. It's amazing, and something that we are going to for sure be standing on your shoulders and trying to get moving in that direction continuously. So I see Dr. Burke has a question. And it is, has there been any preliminary findings on how the M110 funds have been used effectively or not? Any insights to guide other states' investments with new opioid settlement funds?
Yeah, so we have a pretty good breakdown on, and I don't think there's actually a slide in this deck breaking down. We have a pretty good breakdown on how the money has gone out. I think because the majority of this money literally just landed in our bank accounts like 2 months ago, it's really too soon to see what investments are going to have the biggest bang for the buck. They're all really, what we're funding is all really evidence-based practice that is long established as being effective in helping people who use substances. So I feel confident that it will work. And I think that Oregon is a very diverse state, and what is needed in the Portland metro area looks very different than what is needed in some of our more rural and frontier counties. And so there has been, we know how the money has moved, but it's too early to say whether or not it's effective, because that investment has just gone out. I think opiate settlement money is a great funding pool for all kinds of services. I think that in terms of like, we were pretty fortunate, like we went for the cannabis tax revenue in part because like people really like the idea of that revenue stream being used for drug treatment. And the amount of money we were generating from cannabis tax revenue in our state was considerably higher than ever anticipated. And so like when we went for legal cannabis in our state, they anticipated about 94 million in tax revenue to be generated, and we were looking at close to $400 million in tax revenue in the last biennium. So we chose that stream, but I do think the opioid settlement funding is a place to look for some of these supports and to be able to provide these funds for sure.
And next question from Dr. Clark is the question I was going to ask as well. Is fentanyl included in the heroin allowable quantities?
No, hold on, I have to look. I do have that written down. It's not in that table. Fentanyl initially wasn't in our list. When we passed the initiative, fentanyl wasn't called out on its own. However, it was added in through the legislature. And so the threshold for fentanyl is under 5 grams is a Class E violation. Currently over 5 grams of fentanyl is a felony. We did not create a misdemeanor fentanyl, which I think we're going to fix in the legislative session this coming session. There's talk of creating a middle ground, so it's more in line with the structure we have, where it's misdemeanor at certain thresholds, felony above that. But I don't know where that has landed yet. And so the legislative session opens next Tuesday. So I do think that there will be some movement around that 5 grams of fentanyl being over 5, that line of hard violation to felony will have some wiggle room happening when it comes to fentanyl.
Okay, so I'm sorry, I apologize, even. I don't know.
No,
probably just me. So is the threshold 4 grams higher for heroin and fentanyl, or is that currently a felonious charge at under 5 grams? Does a person receive a misdemeanor felony charge, or does it fall under your decriminalization?
For fentanyl, are you asking about heroin with fentanyl in it?
Any sort of fentanyl.
So one, we don't see a lot of fentanyl in our heroin. that's just not really what we see. Based on crime data and by our own FTIR data. All of the heroin we've tested using our FTIR has all been just heroin. But so right now, if you have less than 5 grams of fentanyl, it is a ticket. It's a violation. If you have more than 5 grams, it's a felony. I am confident the legislature is going to probably go to like 1 gram of fentanyl or less is a violation. 1 to 5 is a misdemeanor. Over 5 is a felony, is my guess. I haven't seen the actual legislation yet. It's just a legislative concept that someone asked me to weigh in on. So I'm going to assume they're going to follow the heroin marks for fentanyl, but I'm not confident of that yet.
Thanks, Haven. And Dr. Clark also said, thank you. We do not see much heroin in our fentanyl, which unfortunately is really the case out in Rhode Island.
I mean, the East Coast is very different than the West Coast in terms of how our drug supply looks. Like, it is a different animal. I mean, and that's why like overdose death rates in Oregon have been considerably lower compared to the rest of the country for a really, like, our addiction rates are higher, but our overdose death rates have been lower up until the last couple of years when like really it has been probably the last 2 years. Like the number of people who've switched from injecting heroin to smoking fentanyl is like bananas. The number of people, like we are seeing like our visits to our SSPs have declined dramatically. The number of syringes we are handing out has declined dramatically because of people transitioning from injecting to smoking.
Thanks. And Ian Knowles asks, I think you said that the civil fines and tickets are counterproductive. Do you think that the legislation would have passed without those provisions?
I don't. Truth be told, I think that people, the idea of like carrot and a stick is in people's minds a lot. So no, I think that like strategically, I think it was a good idea in terms of getting it passed to be like, well, we are like doing something when we catch someone with drugs. I think that really helps voters vote for it. I think if you weren't going to the general public, if you were working with like legislature to do some of these changes, I don't know that you would need to do that in the same way. Because you could have those conversations with a smaller amount of people about why it's not that helpful. But I do think we had to have it in there in order to get this passed.
So Carla asks, do you know if there has been any change in the age of first use of various drugs as a consequence of this law?
It's too early for all of that. Those evaluations are ongoing. Based on what I see in terms of my client population and what I see in our SSP in Portland, which is a small demographic, right? Like it's a small subset of people who use drugs. Actually, our median age is going up and has been for several years. Of like the median age of our participants is increasing. Again, that doesn't speak like that is a very narrow subset of who, and growing narrower as people are transitioning to smoking, subset of people. But our average age is going down. But again, I don't know that has anything to do with 110. I think it's too soon to have that kind of data.
Another question is, what is the current plan or model to use 110 funds for social support, wraparound services, and or research being done to determine the most effective ways to do so? And
yeah, that's a great question. I mean, because 110 funds are specifically to be used for non-Medicaid billable services, it really is mostly wraparound services that have been funding, like harm reduction services, housing services, peer support services. Those kind of services are employment services, like those kind of services are what 110 is funding. It's not really funding detox. Like you can use, like we have some funds set aside for Measure 110 for folks who are uninsurable. So like our primary care clinic has a pot of money that for anyone who is uninsurable, that wants on medicine for addiction, right? We can provide them that care out of those funds. But if we could bill Medicaid for it, then we can't use those funds for it. So like inpatient treatment, detox, all of that is Medicaid billable here. And so like these funds are not to be used for those services. I know several like medicine for addiction, like clinics that have been able to hire peer recovery support staff with these funds because that's not Medicaid billable here. Like those kind of supports can be used. So like you're not excluded, but from using those funds, you just can't really, you just can't double dip and get Medicaid money and 110 money for the same service. I hope that answers that question.
Thank you. Brett asks, I guess Brett joined a little bit late in the conversation and asks, do you have any data on the number of police interactions with people who use drugs and if the number of interactions have changed since Oregon's decriminalized?
Yes, there was a whole slide about it. I can show it to you. Hold on.
And Brett, this was recorded, so if you missed the beginning, you can always catch the replay.
Bloop, bloop. Trying to find it. There it is. This is what that graph looks like. I won't talk too much about it because everyone already heard it, but we do have preliminary data that shows a significant decrease.
Thanks, Haven. Dr. Rich asks, are the gram amounts the same if the drugs are 99% pure or 1% pure?
So one, none of our fentanyl is even close to 100% pure. But because it's just not, it has nothing to do with pure, like no one's doing purity testing based on weight for anything. And that's always been true in turn, like, you know, I think we think about it and talk about it with fentanyl differently because it is so caught because it has to be. But you know, it's always just been like general, like if I got a brick of cocaine, they're not measuring how pure it is to decide how much you have, right? And so that hasn't really changed. It's just based on sheer weight.
Great, thanks. Does anyone have any other questions for Haven, or we seem to be out of them for the
moment? Well, Haven, this is really fantastic. Really great talk and great work. And I just want to point out a couple things. The first is that this is just the beginning. That this is a long-standing fight, and having that law, you know, under your belt, first of all, doesn't mean that you're going to keep that law. You have to ongoing fight because people are trying to take it down.
I know. I'm ready for the legislative session.
Well, and people are going to put, you know, because you're the first, the whole world's attention is on you. And people that disagree, I mean, there's the haters out there that are going to put money into campaigns to take it away.
Yeah.
But there's also, you know, I kind of learned this from taking a careful look at Portugal. Because Portugal has been doing this for 20 years, over 20 years. And, you know, the law was an important part of it, but it was just part of it. Having the law is not what made all the difference. It was, I would say it's a necessary but not sufficient. What they had is João Goulão running the program for the whole country and really pushing common sense at every juncture, at every, you know, common sense, caring, appropriate harm reduction policies, strategies, educating at every level. You know, it's an ongoing struggle, and what he's succeeded in doing is changing the culture. And so that's your real challenge here. That's all of our challenge, is to really change the culture so that because and we're fighting against 100 years of punishment of bad, drug, you call somebody a drug, you say the term drug addict, this it's a derogative term, first of all, which should be, you don't say, diabetic is not
Insulin
a
addict.
Insulin addict, yeah. So you use the word addict in there, and all of a sudden, we are all grown up in this culture to think of criminal, of bad, of, lesser than, and therefore it's okay to lock them up. It's okay to treat people poorly. And so that's what you're fighting against, changing that culture. And, I think I think I fear that fentanyl is going to really come into your state in the way it came into ours and many others. And that's going to change a lot of things. So I wouldn't be surprised if your overdose rates go up.
I'm not. I mean, we're like, we are seeing, like, it's really
bad really when it
hard.
comes in.
It's been really hard. For sure. And I do agree that, like, a lot of it is a culture shift. It's been really fun because this was a statewide campaign, really having those conversations around, like, substance use as a healthcare issue, and, like, really seeing people I didn't anticipate being supportive of that shift and making that shift. People who never had that language before started using that language. And I, like, while I do think, like, there are plenty of groups that are going to try and come for this cannabis money, I think seeing the investments rolling out in parts of our state that have never had any investment, it's making people a lot less reluctant to take that funding away. I think last legislative session, law enforcement were coming for some of those funds. We're not seeing that coming forward for the next session as, like, services are starting to scale up. So I do think, like, there is that culture piece that does need to change. And, I've been doing this work. I've been, like, working in harm reduction for 20 years at this point. Like, I've never seen, it's so much better now than it's ever been before. I actually have a letter on my office wall from 1989 from the Oregon Health Authority saying they would never support harm reduction. And I keep it framed on my wall for those moments when I'm frustrated about, like, things not happening fast enough and, like, not enough happening. I can, like, look at this letter and be like, okay, in my lifetime, they said no to doing this work. And now they have me in every meeting they can get me to. If it was up to them, I'd be in all of them. So, yeah, I mean, I'm down for I know, again, like, getting something passed is the easy part. Getting it done is a much bigger lift. And I've been at it 20 years. I'm not done.
Yeah.
So Hayden, we have about 1 minute left and one question, if it's okay.
Yes, please.
Do wraparound services include transportation to clinics or recovery centers?
You can totally use funding for transportation, yes. I mean, I bought 2 vehicles. So yeah, I mean, how different organizations are doing it. Like, we budgeted for, like, money for transportation for, like, our peers to be able to take folks they're working with to meetings, to services, to the clinic, like, all kinds of things. Some of our rural communities have really put a large chunk of this towards transportation because it is such a barrier in our state. We have counties where you have to drive 4 hours to the nearest methadone clinic.
Thanks, Haven. And we are out of time. So Dr. Rich Haven, do you want to wrap this up? And I thank you. We all thank you.
Thank you all so much for having me. I hope it was helpful. If anyone has any questions, comments, concerns, please reach out. I would love to be helpful in any way.
We hope to follow your example.
Let me know how I can help.
Wonderful. Okay. Thank you.
Thank you.